Hello, and welcome to another podcast. Today, we're going to talk about heat injury management. Now, I completely understand that we talk about heat injury management a lot, and it does come up in a lot of conversations. But despite that, there still seems to be a whole bunch of confusion, and in some cases, mismanagement or less than ideal preventative measures put in place that I feel we could maybe do a little bit better. So today, we're going to complement the presentation that's done on evaluating heat risk, and we're going to look at what the data says about the best management for heat injuries as a class. So when you have a closer look at heat injuries, it's really hard to sift through the data because there's a lot of overlapping complexities. It is the leading cause of death when dealing purely with climate-related deaths, and it has been noted as the third leading cause of death in US athletes, particularly the young athletes. Now, when you look at the spectrum of heat injuries, around the 5% mark seem to present with heat stroke. So of all the heat-related incidents that actually go to the hospital, 5% of them are associated with heat stroke. Now, overall, all the numbers we get and all the data we have associated with mortality, it has a 0.1% mortality rate. Now, you may think that that is pretty good. You need to remember that heat in itself is largely predictable and definitely preventable. So really, any cause of death isn't actually that good, even though the numbers are quite low. When you break the numbers down further, the numbers don't look as good as 0.1% mortality. If we look at heat stroke itself and ignore the rest of the spectrum of heat injuries, then it can go up to 27% mortality. And the survivors tend to have long-term problems. And if we get that same data and break it down further, then we just look at the military. Military is considered a very high-risk environment. And one of the leading causes of problems in the military for Australia and the US is heat itself. So our numbers tend to increase if we just look at military cases themselves. And if we were to break down heat stroke further, and we should just focus on heat stroke associated with prolonged heat stroke in the absence of cooling or any temperature over 41 degrees Celsius, then we have an up to 50% mortality rate. Okay, so when you're looking at numbers associated with heat injuries, it's easy to get confused, it's easy to get swayed a certain way, and it's only when you find certain milestones and characteristics of patients that we can sense a true understanding of how dangerous heat can be. So the data associated with temperatures over 41 degrees or that prolonged delay in the management of heat stroke has up to a 50% mortality rate. So 1 in 2 casualties will die on us in those particular cases, which is immense. So let's spend a bit of time talking about what heat illnesses is, how they occur, and then what we can do about it as far as best management goes. Starting off with a little bit of a talk on pathophysiology, it starts as you would expect, as we've already discussed in other lessons, is when you get exposed to heat, either through exercise or external temperature, your body starts to go into stress. You start to have some sort of stress associated with that heat. Now, in the event your body can't handle that stress, for whatever reasons, the factors we spoke about before, then that can get out of hand quite quickly. But what always happens when we get exposure to heat stress is we have an increase in metabolic rate. So that means an increase in energy demand and an increase in oxygen demand as well. Now, our body also detects an increase in core body temperature. Now, when that happens in the immediate acute sense, our body tends to sweat as a means of compensation, okay? Because normally we're not sweating, we're just doing the other means of losing heat through radiation, convection, and conduction. So our body will sweat to add evaporation to the equation and to increase the probability of losing heat. When it does this and it detects a higher core body temperature, it also increases our cardiac output. That increases blood flow to our skin, but decreases blood flow to our visceral organs as a result. Okay, so we have an increase of blood being pumped around the body, but it's actually a decrease of perfusion to our organs and an increase of perfusion to our skin to help us lose heat. That's how it works. Now, this is generally fine. We can compensate with this, no problems at all. Basically, if we're able to cool down, or we're only doing it for a short amount of time and then we can recover, then it's no problems. Our body cools back down, our metabolic rate reduces, and we're fine. When it continues and it goes into that non-compensatory stage, then things get quite complicated. And generally speaking, a bunch of theories or contributing factors add to exertional or exercise-related heat stroke. Now, those 4 principles have been labelled thermoregulatory and cardiovascular limitations, leaky gut hypothesis, or just leaky gut syndrome associated with the release of endotoxins, so endotoxins going into the blood, systemic inflammatory response syndrome, and coagulopathy, in some cases DIC. So we're going to spend a bit of time talking about each of these and what happens in those stages that all lead to the person collapsing and coming under the effects of actual heat stroke or moving from heat exhaustion into heat stroke, which makes them a lot harder to resuscitate from. So starting with the first one, the thermoregulatory and cardiovascular limitations, it's obvious to think that impaired thermoregulation can be one of the contributing factors to hyperthermia because patients are often hypothermic at the time they collapse. Now, the person's ability to thermoregulate is closely linked to the ability of the cardiovascular system to cope with the demands placed on the central and the peripheral blood supply. So if you imagine your whole bunch of blood going to the skin and moving away from the organs at the same time is often coupled with skeletal muscle contractions. When the skeletal muscles are contracting, they actually have a 15 to 18 times greater demand on metabolism, so energy and oxygen, than basal metabolic rate. And most of the heat is transferred from the muscle into the bloodstream to be carried around the body and actually contribute to the core temperature. Now, if we were to take away pretty much every other equation and we would just have a person working out, in the absence of any coping mechanisms, a patient's temperature will go from 37 degrees to around 42 degrees in about 25 minutes of exercise, okay, without any coping mechanisms alone, just purely based on muscle contraction. Now, heat isn't the only variable, okay, because cellular tolerance can be around the 40 to 45 degrees Celsius mark by itself. And most of the time during exercise, your temperature will naturally get up to around 40 to 42 degrees without any problems at all, especially in athletes and those that are acclimatized well. But when you add those effects to other things that are happening during hyperthermia and exercise, like sweat and the inability to lose heat through evaporation, depending on the humidity in the environment, then we get other contributing factors. And some of those contributing factors link to the cardiovascular system playing a bigger role in heat stroke than just the temperature itself. So in order to sustain exercise, your cardiac output has to match the demands for the blood flow. So blood flow has to go to the active muscle in order to meet the oxygen demand. But at the same time, it wants to send blood to the skin in order to meet the demands of thermoregulation. So you have a mixture of vasodilation occurring at the skins, and you have a whole bunch of blood pooling in the muscles as well. Now this obviously gives a complete reduction to blood to the gut and the renal blood supply, which can then lead to problems associated with lack of excretion and filtration, and obviously lack of control when it's got to do with the gut. Now that leads to the leaky gut hypothesis and the associated endotoxemia. Now this is something that occurs most patients who have high-end heat stroke. Okay, so it doesn't happen all the time, but what happens after the person is exposed to these conditions that we just spoke about for an extended period of time is their intestinal permeability actually increases. And the bacteria, and in particular the endotoxins within that bacteria, tend to leak out. Now, in the event the liver is still healthy, the liver can compensate for this. But unfortunately, in catastrophic cases of heat stroke, the liver tends to get damaged as well. So in the event the liver gets damaged and then is hit by these endotoxins, then that compounds the issue associated with the systemic inflammatory response syndrome. Now that is basically a way of saying that there's a dysregulation defense response of the body that's associated with some sort of noxious stresses. They can either be the endotoxins that we just spoke about, but you can also have just general inflammatory cascades that are encouraging end organ dysfunction and eventually death itself. And the final aspect to the equation comes into coagulopathy. Now, obviously, that is a process of physically changing the physiological state of blood from a liquid to a semi-solid. Once vascular repair is achieved, and you go through that final clotting stage, then we have the fibrinolytic factors known as plasminogen coming in to basically lysase and clean out some of the clot. When the patient goes through heat stroke and it is in this state, we actually get a condition known as disseminated intravascular coagulation, or DOC, which is another way of saying hyperfibrinolytic coagulation, okay, which will lead, or can lead, I should say, to thrombotic events and excessive bleeding at the same time. So as you can see, a very complex situation is occurring within heat stroke. The body wants to compensate and meet cardiovascular and thermoregulatory demands at the exact same time, but that comes as a direct consequence to the gut permeability, which leaks endotoxins into the system. Now, the system that picks up the endotoxins is coupled by other pro-inflammatory mediators, which causes our systemic inflammatory response syndrome, which is another way of saying septic shock, or it's very closely linked to septic shock. And then that couples with coagulopathy. The end result, we have a person who needs to be in a state where their blood is controlled, either in their muscles or in their skin, but as a result of a cascading effect, has actually caused profound vasodilation, which in turn messes with the clotting cascade and messes with the overall perfusion of the patient, causing them to collapse. After the state that they have collapsed from this situation, they are very, very difficult to resuscitate from, and it's the associated lack of perfusion to the organs and certain organs that are being very sensitive to heat that overall lead to the death of the casualty. Now, as you could imagine, this pathophysiological response isn't immediate, and you'll tend to get signs and symptoms that this end result is probable. And that's where we get our spectrum of heat illnesses. So as you can see in the slide in front of you, we have a mixture of lower level, if you will, or medium risk conditions where we're dealing with a heat rash, heat cramps, or heat syncope. Okay, they're early signs of potential larger problems later on. And then we move into the realm of heat exhaustion. And if heat exhaustion isn't treated, or if the patient is still exposed to extreme environments, then that moves into our heat stroke, and in particular, our exhaustional heat stroke, which is a little bit different to our classic heat stroke that you may or may not have read about. So we're going to spend a little bit of time talking about the small stuff because it often gets overlooked. And realistically, it's the trends associated with these smaller or mild forms of conditions that can tell us a whole bunch of information about the environment and certain risk factors. So when we look at heat edema, it's best categorized as widespread symptoms, which is characterized by that gravitational soft tissue edema. And this is obviously due to vasodilation and the redistribution of blood flow and that third spaced shifting. Now, this typically involves the lower limbs, and it's resolved by placing the legs in the supine position, and we don't need anything else really. You just place them down flat and allow the body to pick it up, rest the casualty. We move into muscle cramps associated with heat. They're a very common and benign form of a heat disease or a heat injury. It manifests in the short term in those muscles that are subject to the most stress. So it's often calves or legs that get it in these cases. The cramps are often triggered by prolonged and intense physical activity, as you could imagine, especially in people that are unable to acclimatise to the working environment. The patient is often lucid and may report a thirst and fatigue. The onset of pain and the cramp can be rapid, or in some cases it can actually be a gradual onset, so you have to be aware of both types. The most widely accepted reason for these cramps is neuromuscular control theory, which is basically another way of saying that the muscle is able to contract and then has trouble letting go. Okay, that's what the theory basically is. Now, treatment for this includes electrolyte replacement, stretching, and sometimes gentle massage. Heat rash is one of those things that is very irritating and can be quite painful, and it's associated with clogged pores or trapped sweat in the skin, causing a very red, papule-based or even pustule-like rash. The areas that have the clothes is often where you'll get it the most, usually on the chest or the back. Moving the patient into a cooler environment, the rash doesn't tend to hurt as much. If you need to keep them in the warm environment, it's sometimes necessary to remove the excessive clothing and then basically clean the skin. The disorder itself is often self-limiting, and when you get out of the area, it tends to go away. But if you're stuck in the environment having to deal with a heat rash, you can wash the skin area, encouraging the pores to be clear, and then basically treating it that way. The use of powders and anything like that is only encouraged if the person is going to be in a cool environment thereafter. Don't get in the habit of putting powders on the person and then having them be clothed in that hot environment, because the powder turns into a paste that clogs the sweat pores further, makes it worse. Okay, so only use those powder if they're going to be in a clean environment and a cool environment recovering. Tetany itself is often confused for muscle cramps, and tetany can be distinguished by the form of appearance of the actual hands or feet spasming. It's got to do with a shifting of calcium ions. The same thing occurs in hyperventilation, and it's just a matter of resting the patient, having them control their breathing, and getting them to stretch the hands out. The last one we'll look at in this category is our exercise-associated collapse. This occurs very frequently and is characterized by a high body temperature, and it can be due to a lack of water or a lack of salt, resulting in volume depletion. The first situation is typically for the older generation. They have a lack of water. The second is more characterized by a lack of electrolytes, usually associated with a poor salt intake. Things that can make it obviously worse is an increase in peripheral vasodilation and a decrease in vasomotor tone. It usually can accompany serious exercise. Now, when we're looking at the symptoms of these, you can have people that are agitated, confused, thirsty, or with a headache post the actual syncope itself. Syncopes are often short-lived and resolve with the patient lying down flat. So the treatment is obviously just getting to do that supporting. If they can't control themselves when they get up, then the person will need to be removed from the environment until they can fully recover. But the general rule of thumb is when you see these smaller things, don't ignore them. Okay, don't ignore the actual characteristics of these, because if many people will start getting these, you have a high risk environment for things getting worse within that workspace. Okay, people that have any of these mild forms, if they go back into that workplace, which they can, they need to be educated on the risks and then watched for further trends and told to come back at the earliest signs of heat stress being generated. Okay, so moving on down to what do we do when someone actually gets into a larger heat stress? So looking at that heat exhaustion versus heat stroke. Now the biggest difference is, line in the sand as you will, is the involvement of neurological impairment. So if someone has associated heat stress with neurological impairment, they have heat stroke until proven otherwise, okay? And that's how we manage them. If you have someone who is hot, but their neurological faculties are intact, we don't ignore them, but they're not as bad as heat stroke. The goal is you have to cool them. Okay? You have to cool them as quickly as possible. Okay, so use your helpers. Use the people on the ground to cool these individuals. Now, the big question often comes up is, do we cool the individual or do we work on evacuation? Now, the answer to that question really comes down to where is the best cooling going to occur. If you have the best cooling methods on site because of planning, then you keep them on site and you cool them first and then you evacuate them for further care. If your cooling methods are subpar, then from what we discuss soon, then it is best to evacuate those individuals whilst cooling the best you can to get them to an area where they can cool better. Now, when we talk about cooling methods, there's a whole bunch of research that's been done on the best cooling methods. But unfortunately, as you could imagine, the best cooling methods take a lot of planning. So in the event a planning consideration has been done, and you think there is going to be a high risk of heat casualties, it is best to have one of these cooling methods available. So on-site cooling prevents treatment delay, and cooling interruptions associated with transportations to medical facilities is often not the best case scenario, as we just spoke about. So what cooling early does, it reduces organ and tissue temperature, which is the most important aspect because it reduces that further damage. But it also shifts our perfusion because it causes vasoconstriction of the blood vessels, which encourages blood flow to those organs while still allowing the body to be cooled. Okay, so that is a wonderful byproduct, if you will, of cooling methods. So the primary goal of pre-hospital cooling is to rapidly lower the body temperature to a normal range. Now, whilst they've tried to graph the best amount of times in cooling and how fast you need to cool things, they haven't actually come down to a best number, if you will, but what they have found is that if you have cooling rates that are faster than 0.08 degrees Celsius per minute, then they appear to be, pretty good. But if you're able to get up to cooling rates that are greater than 0.15 degrees Celsius per minute, they have the best desirable outcomes associated with morbidity and mortality. So from that, they did research on cooling methods to see which ones actually meet the 0.15 degrees per minute ability to lose temperature on a patient. And those two methods were cold water immersion and the Quantico method. Now we'll also talk about something that has been coined the taco and the ice sheets, which are highly effective when the first two aren't able. So the first one, which is no surprise, is that cold water immersion. This is the best means of cooling someone. So this is when you literally submerge someone in ice water slurry. Okay, so it's like taking an ice bath. You put someone in the ice bath up to their head, basically just the head sitting out, you get a sheet, you wrap it under their body and under their arms so you can hold them, helps transfer and stops their head going under, and you make sure their whole body is in the ice. Okay, and that's obviously the best method. So you can imagine how much effort that takes to set up and keep. So it's often difficult to do. So the other method, which is just as good as the complete or cooled water immersion, has been coined the Quantico method. And this is where a stretcher is placed over the top of an ice bath, but instead of immersing the person into it, a whole bunch of series of sheets are dunked into the water and then placed over the casualty, like their legs, their ankles, their groin, pretty much where the large arteries are, and then they're rotated. Okay, so it's like pretty much like a method that we're going to talk about soon, which is just the ice sheet towels with ice pack method, but we have the advantage of having the ice bucket really close by and a large amount of water that you can rotate through. Now those two methods have been proven to meet the 0.15 degrees Celsius per minute loss that is optimal in mortality and morbidity rates improvements. But as you could imagine, they take a lot of people, a lot of logistics, and you pretty much have to have them set up on site in order to be able to do them. So in the event these are not possible, other things you can do is have similar methods set up that aren't as fancy. And they're what's known as mobile treatment. So you can either do these whilst the person's in a vehicle going to a facility, or you can have them set up temporarily whilst the other facility is setting up. So TACO, which is a tarp-assisted cooling with oscillation, is basically making a makeshift ice bath where you get a tarp or you get a body bag or a bivy bag and you punch a whole bunch of ice water in it and you put the patient in it and then you rock them around because obviously there's not enough as much water as an ice bath. You want the movement of the ice water to go around in order to prevent stagnation and stopping that cooling method from transferring. So you place them into the body bag with the water and the ice and you rock it back and forth, oscillating the water within it, which cools them down. Okay, so a bunch of water and still a bunch of ice. The other method that's been proven pretty good is ice sheets, towels with ice packs, where we have an esky or a small portable canister with water and ice in it, and you dump a bunch of sheets and ice packs in it, and you will place them on the casualty, and then you'll take them off. Usually no longer than 3 minutes, and sometimes, depending on the person's temperature, 30-second rotations. Now, leaving the ice sheets and towels on the patient too long can actually trap heat. They can reduce the cooling rate further, which can make it worse. Okay, so it's very effective to place the sheets on there whilst other sheets or towels are in the bath. You pull them out, wring them off a little bit, and then you place them on, swapping them over. Same as ice packs. Put the ice packs in, swap the ice packs out. Okay, so you don't trap the heat. But these are the methods which are a little bit different to the ones that are usually discussed. And these are the gold standard methods for treating someone with heat stroke in particular. So if someone has heat stroke, these are the methods that we need to aim for. If someone has heat exhaustion, then we can use the usual wetting the casualty, drying them off, fans, spraying the casualty with spray bottles, moving to a cold environment, taking their excessive clothes off, things like that. But as soon as we hit that heat stroke realm, and that's what we're dealing with, we should be fighting to get these advanced methods and evacuating someone with the basic cooling methods until we can get to a facility set up that has these methods there. And if you're in an environment where heat is predicted, then these methods and the logistics for these methods should be sought after in order to really protect people. Okay, so that's the basic principles of intake management. Other things you can do is obviously complementary IV cannulation, but that doesn't take precedence over cooling. And in the event someone gets shivering as a result of the cooling or sometimes a complete disruption of thermal regulation, then you administer midazolam. at 0.01 milligrams per kilogram IV, and you can repeat that every 5 minutes as needed, and that will stop the shivering, knowing full well that shivering is only going to increase the temperature of the patient. As the treatment continues, and we get them to the higher facility, we get them into the resus, or we're holding on to them longer after the initial cooling's done, then we need to attach full monitoring. And we need to have the ability to do proper rectal temperatures from our monitors. Never using an oral thermometer as a rectal probe is completely ridiculous and it will not work. So proper rectal probe as we continue to cool the patient to the desired temperature. Okay, now it is a good idea in literature to have a rectal probe in there fully, but then keep taking tympanic temperatures. What they've found in a few cases, few too many actually, is there's actually a delay between cerebral temperature and rectal temperature. So when you're aiming for a temperature of around 38 degrees, you'll find that people will often overcool, relying on rectal temperatures. So it's best to have a rectal probe in place, constantly taking a temperature, and then continue to take tympanic temperatures throughout. Things that you can do is obviously IV fluids. Run an IDC because we want to test for things like rhabdomyolysis. We want to know about urinary output, and in some cases, if the bladder is empty, we can also use the IDC to place cool water in the bladder in order to encourage further heat loss as well. But we definitely need to know the risk factors associated with renal function from our urinalysis. So that's at a bare minimum. We also take our bloods. We want to know UNEs, we want to know liver function, linking back to liver function being the contributing factor associated with leaky gut and endotoxemia. If you have endotoxemia and the liver is fine, you'll have no effects. But if you have it and your liver's not, then you can have the associated link to SEERS. So we want to know that. Blood gases are great to know, same as lactate, to understand the person's shock state and how well they're doing. Now the PCCM tells us to stop cooling or actively cooling around the 38 degree mark to prevent overcooling. Now there's mixed data out there, but because we follow the PCCM, that's where we start with. At 38 degrees, we stop cooling, but we definitely do not return them to the environment, and we prevent them from heat exposure thereafter. Now, after the resuscitation of our casualties, the casualties are often in for a long haul. If someone has heat exhaustion and we've decided to evacuate them from the area for management or further investigation, then they can generally return pretty quickly as long as everything comes back normal. If someone's actively been resuscitated from heat stroke, especially if it's prolonged heat stroke or a temperature over 41 degrees, then they often will have long-term problems, and those problems can be associated with their ability to maintain employment within defence. Okay, so just keep that in mind. The recovery is often done in hospital, and general markers have been placed in order to ascertain whether or not they're improving or whether or not they can be released from hospitals. And these generally relate to neurological status, creatine kinase levels, which is highly associated with heat stroke. Big spike can take a few days to actually clear. Kidney function is obviously a huge thing we want to make sure is actually still working, as too is our liver function test and our coag studies, depending on how bad the heat stroke was. Bottom line is each facility and each area will have their own metrics of recovery, and sometimes patients will not fully recover from heat stroke. It can lead to lifelong debilitation and problems that will have no resolve. Okay, so it is absolutely in our best interest to do all we can to prevent a casualty from getting heat stroke. Now, this is simply done by being true to our risk analysis, by advocating for our patients with correct management and protection at the early sign of heat-related illness, aggressively managing all casualties with heat exhaustion, and maybe even erring on the side of caution whether to evacuate them from the area or not. And in the unlikely event we get a casualty with heat stroke, especially if we're doing everything right, we have the proper cooling facilities set up in environments where high risk profiles are in place, and we're able to aggressively manage these casualties to prevent them from getting to 41 degrees Celsius core temperature or being in a prolonged state of heat stroke in order to prevent mortality and morbidity rates. But until next time, take care.